How do you do neonatal resuscitation? What are the specific precautions do we need to take while attending a delivery of neonatal resuscitation? Is the breastfeeding protocol different? One second, I think it is asking me to continue. Okay. NICU admission policies. Do we need to take any specific precautions in the NICU when admitting these patients? What should be our visitors policies? Because with such a pandemic and many of the asymptomatic people turning out positive, what happens to the newborn babies who are admitted in your unit? What happens to your nurses is one of the biggest crises which we are facing. Should you continue KMC guide? When should you test the babies? How do you treat neonatal pneumonias, which we didn't see in the first wave so many? Should we use remdesivir? Should we not use remdesivir? Should we use sort of immunoglobulins? Should we use steroids? These are some of the challenges many of the pediatricians and neonatologists are facing. And of course, how do you keep the staff motivated? How do you prevent the staff from getting positive? This is one of the biggest challenge as a pediatrician and neonatologist we all face. Now, how does a newborn get COVID? There have been enough evidence to say the vertical transmission is very rare. There have been some occasional case reports where IgM antibody has been documented, but many could not document COVID virus in the amniotic fluid or the placental tissue. But intrapartum transmission, COVID being positive in the first 72 hours has been well documented. And many of them have been positive after birth by postnatal exposure, which is what is postnatal transmission, either being exposed to mother who's positive or exposing to any of the family member or caretaker who's positive is a common way. And this is what majority of us, I'm sure most of you who are managing newborns who are COVID positive are witnessing in the second wave that newborns are typically coming in the second week or third weeks with fever and turning out to be COVID positive. So you can divide neonatal COVID into two. One is early onset, a late onset, and one very important thing which majority are discussing is multisystem inflammatory syndrome newborn. We're seeing multisystem inflammatory syndrome in children. It's not very common in newborn, but yes, it is seen. I can share one of the cases which we saw last year. But I would say nearly 70 to 80% of the newborns are asymptomatic, and COVID is an innocent bystander. So let us talk about COVID and pregnancies. Looking at the RSOG's recent reports and many of the trials, we have two large registries. One is pre-COVID-19 systematic review, which looked at nearly 64,000 pregnant women worldwide. Another was the priority, that is pregnancy coronavirus outcome registry study, which is a USA sort of ongoing study which is there. They looked at what is usually clinical symptoms in pregnancies, what is the outcomes of pregnancies who are COVID positive. Nearly 2/3 of the pregnant women are asymptomatic. However, they have higher rates of intensive care unit admission, not that they are necessarily sick, but because probably we want to be more sort of careful with them, the threshold of admission is a little less. However, though, if you look at earlier reports, they said probably the death rates are similar, but lately they found that they are at least increased risk of death rate compared to a non-COVID mother or a pregnant lady who's not COVID. In the second wave in India, definitely we are saying more mothers getting sicker compared to what we saw in the first wave. And I'm sure if we correct data from the Indian registry, we'll find, and this is one of our sort of our own observations, and I can share our data toward the end.
Will be carry on.
Sorry, can you hear me? Sorry. Okay. Symptomatic maternal COVID. So what are the effects is that? So fortunately, COVID does not cause any major problem to the fetus. There is an occasional report of stillbirth or something, but majority of the time there's no fetal defects.
No.
There are no fetal growth restrictions. But this iatrogenic preterm is what has been reported. The pre-COVID systematic review suggested the risk of having preterm has increased by nearly at approximately 17%. If your standard is around 8 to 10%, it is around 17%. Some have reported as 22%. Even looking at some of the systematic reviews, looked at nearly 32, if the odd of being born at less than 32 weeks or odd of being born at less than 36 weeks, 37 weeks is significantly high for a mother who is COVID positive. So what really happens is, if a mother is COVID positive, is having respiratory distress, it ends up that they ended up delivering the mother in interest of mother. And that is the reason why there's an iatrogenic prematurity which increases in a COVID. And this is something which has been reported across the world. Now let us look at the common practices. Let me say, the NNF has come up with the guidelines in May 2020. It is looking at revising its guidelines, and I say that probably by next month or so, we will come up with the new revised guidelines. What I am trying to talk to is based on the review of the RCPCH, the American Academy of Pediatrics, the Australian guidelines, and even the Cochrane review. What it has done is it reviewed the guidelines of 19 different countries. And I'm presenting you the data about this, and then we can conclude what probably is good for our country. So what should be the mode and indication of the delivery? If the mother is COVID positive and asymptomatic, the indication of delivery should be obstetric indication and nothing else than that. This is something throughout the country, it has been a universally accepted recommendation. If you look at that, out of the 19 countries, 16 countries have said, 2 countries have not commented about this. If there is a COVID, mother is having symptoms and has to be delivered. Now, this is one of the biggest controversies which is there. Now, we have talking about recommendation from RCOG, Society of Obstetrics Canada, the American New Zealand, Australian New Zealand Obstetric Society, and American Obstetric Society. If mother is having severe or critical COVID after 31, 32 weeks of gestation, which means she is requiring respiratory support, the decision is to go ahead and deliver, because because of the pregnancy, there's a pressure on the diaphragm and it reduces the functional residual capacity. And say if you deliver them, the mother feels a lot more better and the chances of her respiratory distress getting worse is less. Between 24 to 32 weeks, it is discretion of the multidisciplinary team, which includes the intensivist, the obstetrician, the neonatologist, and anesthetist together have to decide whether to deliver or not. At less than 24 weeks, it is based on the maternal condition. Once you decide to give or deliver the mother, then you should go ahead and give antenatal steroids to her. Now I'll talk to this about again, but what antenatal steroids? You give betamethasone or dexamethasone at the regular dose what we give for any other preterm delivery. Magnesium sulfate can also be given to this mothers for neuroprotection. So there's no contraindications. The next is, where should they be delivered? So that is the biggest challenge for many. If you are an individual nursing home, if you're a hospital, that is a challenge. If you're a hospital, you have multiple sort of delivery rooms or you have operation theaters, you have a dedicated delivery room or operation theater, it is better, because the chances of, because you might have other mother who might come for delivery. And I know all of you might have gone through, because those mothers who are not COVID positive, they are the one who get very stressed out if they know that there's a COVID positive mother who delivered. So having a dedicated delivery room or an OT makes a big difference. But that luxury, not every hospital has. So there should be a good sort of practice of trying to clean up the area immediately after the delivery. So we have a separate delivery room, and preferably having a negative pressure isolation room is what is recommended. And this is what they have a screening between the mother and this, because mothers does grunt during the process of delivery. She's put on a mask, but it is recommended for the obstetrician also to wear N95 mask to reduce the aerosol exposure. That is one of the things which we designed, to put a sheet in between the obstetrician and the mother to reduce the aerosol exposure. Where should be the resuscitation cot be? That is the next question. Preferably, if you can keep outside the delivery room or the operation theater, it is good. If you have air oxygen ports, or if you have the air and oxygen ports, it is good. If you have to keep in the same room, it should be at least 2 meters distance away from the mother. Or if you can keep a curtain in between, it will be great. So a physical barrier like a curtain will help in reducing the exposure to the neonatal resuscitation team. So that is how we should be there. So what should a neonatal resuscitation team should be? So it is usually recommended the senior most person should go. The reason behind it that we do not know which baby will need resuscitation. So instead of sending the junior person, the patient not responding, then someone else started going in, and or sending someone in and being available outside the neonatal resuscitation room. So in the case the patient is does not cry, in a PPE is what is recommended. So you need to have your gloves, you need to have your mask, preferably N95 mask, because we do not know which one require intubations, and eye protection, especially when you're intubating, any aerosol generating procedures, and of course the gown is what is the recommendation when you are going for resuscitation of the newborns. Then let us look at the neonatal resuscitation practices. Should we do delayed cord clamping or not? So Cochrane looked at the 19 countries' resuscitation practices, and this was a divided opinion. So 5 countries like China, Russia, one of the European countries, I think Israel, also felt they contraindicated, say, because there was always a concern at the earlier time whether there was a vertical transmission. So they said, no, do immediate cord clamping. Whereas 7 countries like UK, USA, Australia, Canada, they all suggest go ahead. They in fact looked at mother is COVID-19 and symptomatic, mother is COVID-19 and asymptomatic, or you are at risk and you're being delivered, but you are not been, your status has not known, and looked at the recommendations. And that's where you find some of the 7 numbers and 8 numbers. But that is where there's a, divided opinion about, and some countries have not commented about it at all, whether they should go for delayed cord clamping or not. But as all of you know, there's so many advantages of delayed cord clamping to the babies. So how do we decide about it? As of now, the rate of vertical transmission throughout so many systematic reviews have shown that there is a very rare cases of vertical transmission. And that is the reason why the countries which have gone ahead and said there's no contraindication for delayed cord clamping have suggested, because of the huge advantage of delayed cord clamping. The second is skin-to-skin contact. Again, the secretions in the vaginal fluid or in amniotic fluid did not show SARS-CoV-2 virus. And the advantage to mother, not only now, and there's a question of afterwards also, during the KMC time, should we have mother to have skin-to-skin contact, is something which has been reviewed. There is a divided opinion. So countries like China, Russia, as you said, they have come up with their guidelines. The newer guidelines have not come. They were the one in the beginning who were very, very aggressive to trying to separate the mother and baby. They didn't want to do anything to keep a mother baby. Whereas many of these countries like UK, Australia, US and Canada are promoting skin-to-skin contact, and say just take all the precautions like making the mask, and she need to have hand sanitization while doing skin-to-skin contact. Rooming in is other thing which has been, say, after the birth, what should we do? Should we be staying together? Should you be being separate in a different room? So again, see, if you see the first one is most of these countries like Russia and China and Iran, these are the one who have suggested not to be together. Whereas countries like the developed country, many of them have suggested can be roomed in, but mother should wear the mask, she should do hand sanitization, and should keep the child at a distance of 2 meters from not breastfeeding. So because there are so many advantages of keeping the mother and baby together. Some disturbance coming. Is it okay? There's one place where there is universally accepted is breastfeeding contraindicated. There's only one approval, once Lancet, there was one report about finding some virus in the breast milk. But again, there was controversy about the way it was conducted and the way it was collected. Whereas universally, majority of them said breastfeeding should not be contraindicated and be continued for a mother who SARS-CoV-2 virus. So if you look at Breastfeeding, majority would say go ahead and breastfeed. Separation, again, I think majority would say probably no for separation. Whereas there is a divided opinion as far as delayed cord clamping and KMC is concerned. Now, what did our NNF say in the earlier version? And we have not yet come up. The new guidelines are still to come, soon to be updated. We said delayed cord clamping can be practiced in our May 2020 guidelines. We also said skin-to-skin contact can be practiced, taking all infection control measures like mask and hand sanitization. Some of the countries suggested to give bath immediately after, with the concern about, see, the way public sector, private sector, risk of infection, the way the magnitude of the number of patients we manage, we suggested no bath immediately after delivery in as far as India is concerned. Is there anything specific we should do when it comes to NRP and for India is concerned? As far as NRP is concerned, follow the 2020 guidelines. There is no specific changes. There has been concern earlier, you should use TPS resuscitator, you should not use, you should use bag and mask. I think not. Use the NRP resuscitation as per standard guidelines, except that you should wear the N95 masks. Now you should wear the gowns, you should wear the eye gear and while attending, and wear the gloves while attending. That is the only thing which has been suggested. And be careful when you're giving endotracheal medications because of the aerosol genetic procedure. So that is what is sort of the guidelines would say. And I don't see there could be any major change in these guidelines, even when I reviewed a lot of the recent literature. Sometimes it is important for you to sort of do some simulation in your unit to see how it has to be done, what has to be done when you're sort of, this we did in the last year. I can see sometimes what we've actually done. We created our neonatal resuscitation corner outside the unit. And because sometimes it's difficult for the nurses and other things, and some of you might find it difficult with those visor to actually look at the tubing and other things. So practicing is very important. The second thing which had come up, whether to use an HME filter or viral filter, either doing the expiratory port. There are some suggested expiratory port. There are some you suggested inspirate and expiratory port. There are practical difficulties while handling to sort of to deliver the pressure. So majority of doing the expiratory port, all when intubating. These are the HME filter, which are small size filters which are now available by Draeger, which can be used. This reduces the viral load, which can also be used on the bubble CPAP in the expiratory side or on the expiratory side of your ventilator when you're ventilating the child. When you're shifting the child from NICU, from the labor room to the NICU, shift them in a sort of either because of, you mainly shift them to the NICU because they're preterm or they have asphyxia or they have respiratory distress. So shift them in a transport ventilator. What do you do with the breastfeeding?
Okay.
So if mother is asymptomatic or has few symptoms, they should be room in and initiate direct breastfeeding. Hand washing prior to handling the infant, mask during breastfeeding, and keeping a 6 feet distance when the mother is not feeding is what is recommended. But however, sometimes, as I would share, some mothers are very sick. They could be in ICU because they're having cough, fever, dyspnea, or babies in ICU. That's when you need to give sort of express breast milk. While expressing the breast milk, mother should take all aseptic precautions like washing her hand, cleaning herself, wearing the mask so that there's no contamination during expressing of the milk. NNF has come up with the nice guidelines about where the baby should go. You have suspect mothers or you have proven those who are sort of positive. But either way, if the baby is less than 34 weeks or sick one, they go to the NICU. They go into COVID isolation and ICU. If they are well, that is more than 34 weeks, and mother is not sick. These are two reasons. See, I think that each unit will have different sort of challenges, because sometimes you will have some families where there are no caretakers and mother is sick, then they have no other option but to get them to the ICU. Sometimes you have a challenge that, baby is 35, 36 weeker, but having some respiratory distress, you still have to get them to NICU. So if the child is sick, either way they'll come to NICU. If the child is preterm, the child will come to NICU. But if the child will be able to take feed, then and mother is well, preferable to keep it along with mother or a caretaker is what is the recommendation from the NNF. Now, question is, what should we do in the NICU? That is again a major challenge to most of the units. It is based on how big your unit is. Do you have a dedicated space? So when you're designing, if you had 2-3 spaces where you can say, okay, this is the separate space for me. Now we looked at the air handling spaces. So if this does this space have a separate air handling. So some of the units, they have a split AC, then it's probably fine for them. Some of them have a separate air handling unit, that's also fine. So dedicated space is fine. Or you can use an incubator. If you're not using an incubator, at least a 2-meter distance between both the places is what. This is our unit. Fortunately, we have a separate family-centric rooms we had in our NICU. I think Jaicharan has seen when he had come. So we converted this, and this has a separate air handling unit. So we converted this as isolation NICU. And this is where some of all the COVID suspect or positive babies we took there. Now, when do we sort of say COVID exposed, or sort of how do we say that which are the babies who come here? So they are born to mother who was infected with COVID 14 days before delivery, or they're exposed 28 days after delivery, or any caretaker after delivery. If the COVID is exposed, then they come to this and they need an NICU admission. So what are the tests which are available? So we have RT-PCR, we have rapid antigen test, we have CBNAT or TrueNAT test. Now RT-PCR is the gold standard. This is what most of us do. Sensitivity is 70%, sensitivity is good, but the turnaround times depends upon where you stay and how big is the pandemic. See, in the very busy time, and the turnaround time has been at almost 48 hours in some of the places. And I have known some of the district places, they say that it takes 2 days, 3 days for their RT-PCR to come. That's why they go for rapid antigen test. That is a point of care testing. Now, point of care rapid antigen test, the advantage is it's a very specific test, but the sensitivity is very poor, it's around 50%. So if you're positive, you're positive, but if you're negative, it does not mean you have negative. So you still have to send an RT-PCR for confirmation. For CBNAT and TrueNAT, the advantage is it is rapid. It's again, you get a report in 2 to 4 hours, but it's expensive because it is a nucleic acid amplification test. It has again sensitivity, good sensitivity and specificity like RT-PCR, but it does not give you CT value like the way your RT-PCR gives. But what happens with CBNAT is the advantage for this, suppose you have a very small area and you want to quickly decide, I want to know whether this child is positive or not. I want to shift this child to the normal ICU. That sort of pressure is there in your unit. That is when we use CBNAT. Otherwise, I think most of the units will you stick to RT-PCR because of the cost advantage. The question is neonatal testing. Now, neonatal testing is something I've looked at the CDC guidelines, I looked at the AAP guidelines, I looked at the RCPCH guidelines. We're actually reviewing the guidelines for the NNF because based on what we thought we did earlier, and we might be coming up a newer. So suspected perinatal transmission, which means if you are born to a mother who's COVID positive, when should you do the test? So there are some units like Canadian guideline, they say do within 2 hours. There's some who say do at 72 hours. There are some units who saying do at 24 hours. The reason is, if you do very early, there's a chance that you might be picking up a contaminated sample from the mother is the concern which is there. So ideal time, we think, is probably 24 to 48 hours is the ideal time. In the earlier guideline, we were talking about repeating the test between 5 to 14 days, and I'll share that. When we look at the COVID registry, and which was published in Indian Pediatrics, not many people did the repeat between 5 to 14 days. Our own experience has been that some of the people were negative earlier, but came positive afterwards. But if they're asymptomatic, by testing them positive, what difference does it make is the main question. The idea behind testing is maybe quarantining them, preventing exposure to vulnerable people at the house is what is the guideline. So what was the current like taking on the different guidelines? Because there are some like American guidelines say test only if they are symptomatic, like Australian would say test only if they are symptomatic. So what would I suggest at this stage? I think I would say wait for a month, we're reviewing the guidelines and we'll come up definitely from NNF with the definitive guidelines. But say do your first test at the end of 24 to 48 hours. Between 24 to 48 hours, do your first test. If the child is symptomatic, definitely repeat the test between 5 to 14 days. There's no role of serologic testing in this children, like you want to do IgG. See, there could be transfer of maternal IgG antibodies to the baby. So there's no role of testing in the for diagnosing of acute infection. If there's a history of exposure, like there's a baby mother is COVID positive, or there is a caretaker who's COVID positive. So if the child is asymptomatic, do after day 5. You can do earlier if the child is symptomatic, like child is presenting with fever, reduce intake, vomiting, loose motion, or cough. You can do it earlier. If the child presents later, which is what most of us are also seeing, is presenting on 14th day of life, 15th day of life with fever, cough, respiratory distress, sepsis-like feature, that is the time, at the time of admission itself, you will have to do the RT-PCR test to see if this one is, if you have a very strong clinical suspicion, like the first test is negative, as I said to you, 70% of the cases turn out positive. In those cases, you may have to repeat an RT-PCR test again after 48 hours if you strongly think that this one is COVID. Especially if you have say there's a very COVID exposure is there in the family, X-ray showing some evidence of pneumonia, child is mounting fever, not responding, then you repeat the test. Let's look at some of the case scenarios. And these are real cases which we've seen. Mrs. S was referred to us from a district. She had 32-week gestation, presented with fever since 6 days, cough, respiratory distress since 2 days. Her RT-PCR was positive for COVID. Her oxygen saturation room air was 90%. She was breathing at a rate of 30 per minute. Her blood pressure was normal, CNS was normal, fetal hearts were normal, anterior scan was normal. This was a CT scan if you look at. She had a CT score of 15/25. Her PF ratio was just 100. She had worsening distress. A lot of time you do get call. Should I give remdesivir? Should I give steroids? Low molecular weight happening. When we looked at antenatally, like what steroid should be given to mother, there has been again difference in recommendations throughout the different. Some people, not many have recommended methylprednisolone, which we commonly give. Many have recommended dexamethasone, 6 milligram daily. RCOG has recommended to give prednisolone or hydrocortisone unless delivery is imminent. If a delivery is imminent, you give betamethasone or dexamethasone. Remdesivir can be given because it has been found. Earlier it was, if you look at earlier guidelines, they say it was not studied in the earlier trials. But the current study says it definitely has shown to reduce mortality in mother in someone. So I know remdesivir itself is very big controversies. It is a question of at what stage of disease mother comes in. If she comes in the first 7 to 10 days of illness, then probably there's a role. Later stage, there's no role. Low molecular weight heparin, as such, pregnancy is a very hypercoagulable state. So there is a role of prophylactics, low molecular weight heparin in this sort of pregnancy. Because of a low PF ratio, worsening respiratory distress, and need for respiratory support, the decision was taken to terminate deliver the mother after giving antenatal steroids, and LSCS was done. We had a birth weight of 1.2 kg, baby who was born, and we started the baby with the child cried after birth, and we started with sort of delivery room CPAP, and child was shifted to the NICU. Baby was admitted in isolation NICU for COVID positive or suspect babies. Chest X-ray was suggestive of HMD, but the silver underscore was 7. Requirement increased to 45%. Decided to intubate and give surfactant. COVID RT-PCR was sent at 24 hours, and this was the report. It was positive. The next question is, should we send any other test for the baby? Now, when it comes to neonatal COVID, sometimes COVID could be innocent bystander, or sometimes neonatal COVID could be symptom actually responsible. So if you have a symptomatic COVID, which means you have patients presenting symptoms of, so here you do not know the respiratory distress is because of HMD or because of COVID pneumonia. So which you think if it is because of that. Then you do COVID related test. You want to see if an inflammation is there. You want to know whether there's a role of ferritin, dammer, IL-6 like the way you do. Otherwise, most of the time in newborns, you do test to rule out any evidence of infections. Sepsis is what we do in both in early onset and late onset. The second question which I constantly get from majority of the places across the country is the raised D-dimers. Mind you, as such, in mother, the D-dimer gets raised in the third trimester and post-deliveries. And we found that majority of the newborns, in the first wave, when we did not know about this, we were measuring these levels in the first time. Now we stopped measuring it. And we found that the D-dimers used to consistently come raised. Now, if you find an adult, if you have a raised D-dimer, we end up giving them low molecular weight heparin. Now, you have here the dual that you have a new preterm babies who are at risk of intraventricular hemorrhage. Do you give them low molecular weight heparin or not? We decided at that time to silently wait and see what is to be done. And we found that majority of the baby, the D-dimer automatically starts coming down. So there's a big controversy in the neonatal circle across the world to do what to do with this. D-dimer should be anything. And common practice is wait and watch. This baby ensure was done, sonogram was normal, baby was started breastfeeding. The other common thing is, what is the role of antiviral in neonatal COVID? Should we give remdesivir? Is the role of lopinavir, ritonavir? Is the role of chloroquine, hydroxychloroquine? Is there ivermectin? There's no role of any of this antiviral. I think there have been people who have been using remdesivir. I think there have been some case reports of use of remdesivir in newborn. I would say they have been used as a last resort. There have been no, as such, remdesivir report in adults have been being extensively reviewed about when to be given. This thing is we have to be very careful before using in neonatal COVID. Should we give IVIG in neonatal COVID? I would say there's no role at IVIG in just plain neonatal COVID, no role of IVIG. When should the steroids be given? If the child is requiring respiratory support, is probably, and you have a raised inflammatory markers, that is when we should consider steroids in neonatal COVID. The other scenario which we commonly see, and this is something which a lot of us would be seeing, is anywhere between 3 weeks to 4 weeks. And this is real. I got a call, 1-month-old child. This was from a district place. That mother is COVID positive in quarantine. Father is taking care of the child and said, my child is having fever. And he occasionally cough, but feeding well. What should I do? I want to give something at home. That's what he says. And how do you approach such patients? It's very important that we treat anyone less than 3 months like earlier. Fever less than 3 months, the way we treat, we should treat the same. I told the parents, father is, you please come to the hospital. We need to rule out late onset sepsis in this child. We need to rule out UTI. So this child was brought in, examined. We did a septic screen, including X-ray and RT-PCR. The COVID was positive for this child, but the other markers were all normal. This child had urinary tract infection, was treated for UTI, and child got better. So you will have children with late onset sepsis, with UTIs presenting during this COVID time, and COVID would be an innocent bystander, and we don't necessarily have to sort of be aggressive in treating them. The other big challenge comes is some of the aerosol generating procedures and what should a neonatologist do. So this is baby of, and this is a mother and child who is still there in the ICU. 25 plus 4 weeker, CT score of 22/25, core at 6, 100% FiO2, PIB 38/100, in spite of proning, rule out pulmonary embolism, PF ratio was 60, OI was more than 30. She qualified for ECMO. And I'm sure most of you would agree with that. We all struggled to find ECMO beds. The results of ECMO outcome was poor. And we had a lot of discussion with the parents to what to do. And we say, and if you're not sure whether she will go through this cesarean section well or not, we say, let us go through the section to see by doing the section whether that is going to reduce the physiological demand of pregnancy on the mother and whether it will come down. And that is one of the reasons why we did section. And it did make a difference to her. Her oxygen requirement did come down to 80% over the next 24 hours after we did section. We had this 25 plus 4 weaker, 790 grams, who was delivered. And see, mother had atrocurium, she had fentanyl, we had to really sedate her heart because we had to prone her. And she had very poor respiratory, the child had poor respiratory efforts at birth and needed aggressive resuscitation. Means he had a good heart rate, but I think because of maternal sort of respiratory, because of maternal sedation was sort of knocked down. And after intubating also, we were not able to get the saturations up. That's where we give delivery surfactant. So please put on the goggles or the eye shields when you're giving sort of surfactant, is what sort of the message I was saying. This child is still ventilated, was 2 weeks, had 2 doses of surfactant, no IVH, COVID RT-PCR was positive. Thrombocytopenia is extubated to CPAP. Now, the next question which we have is, how do we define MIC in newborn? If you look at, there's the slight difference between CDC definition, WHO definition, and RCPC definition, very mild, maybe the age factor, 0 to 19, CDC is 0 to 21 years. Fever for more than 3 days. This is one thing which we may not find so much in the newborn. And presence of multi-system involvement like conjunctivitis, mucocutaneous inflammation, not seen so much of, but hypotension and shock is something which we are commonly seeing in children, newborn. Cardiac dysfunction, pericarditis, valvulitis is something which is being seen in newborns. And evidence of coagulopathy, as I said to you, is being seen in symptoms in newborns. GI symptoms, yes or not. Elevated markers of inflammation is documented. And most important is for us is to rule out other causes of sepsis. Rule out other causes of sepsis is important. No other obvious microbial causes of inflammation. And then evidence of exposure to COVID, documentation of COVID antibodies or RT-PCR is important for us before we sort of say. You investigate them. The first test of investigation is to do the routine, like the way you rule out any of the sepsis, like do a blood test, renal function, liver function, ESR, and RT-PCR, and of course echo is to be done there. And if you are having raised CRP, raised ESR, you have lymphopenia, platelet thrombocytopenia, neutrophilia, you have any of this too, then you go for, look for cytokine storm. We look at IL-6, we look at troponin levels, we look at pro-BNP levels, and these are some of the things which we help to sort of tie to. Treatment, at this stage, we do not have specific because the cases are so low, there can't be any specific recommendations. We're probably at this stage obliged to follow whatever has been said for the MIC children. I think majority of us are starting seeing MIC in children now in the second waves. We have seen children with bad shocks coming in, and 1 gram per kg on day 1, 1 gram per kg on day 2 is what we're seeing. Methylprednisolone. See, when those who follow the rheumatology sort of see, they give pulse dose, give 10 to 30 milligram per kg. We did not find so much in the children. So last year we saw 84 children with MIC in children. I'm talking about the PIC side. I had one child with the MIC in the newborn. I'll share the case report. And majority of the children, we managed 1 to 2. The pulse dose we reserve for children with shock, with requiring multiple inotropes. Aspirin should be given, and platelet sort of only should be contraindicated platelet less than 80,000. And there have been low molecular weight heparin is only for giant aneurysms when your Z score is more than 10. And anakinra has also been used when sort of you have very bad sort of not responding to IVIG. So this was the case last year with a 12-year-old. This was a very precious pregnancy. Mother had fever 3 days prior to delivery, 27 plus 4 weeks, spontaneous preterm labor, 970 grams, cried immediately after birth. Her heart rate was less than 100. Positive pressure needed by TPS resisted, and intubated in delivery room, and surfactant was given. The babies at that time we were giving early, because the recommendations were, so we were doing early RT-PCR, and we did routine blood tests. The child did well, and we extubated it within 24 hours, had a tiny PDA, but towards day 4 again had apnea and needed respiratory support, started having fever, sepsis was negative. So we did an echo for the child. And that's where we showed a significant mitral and tricuspid regurgitation with dilated left atrium and ventricle with the reduced ejection fraction. And this is what sort of the cardiologist said. When we did the blood reports, we found elevated D dimers, interleukin 6 was raised, ferritin was 880, the pro-BNP was raised, and the troponin was also raised. So this is when it was the first time we were facing this situation. We did not have idea about how, so we said, okay, again, steroids and effect on the brain in the small babies. So said, okay, let's give immunoglobulin. So we gave immunoglobulin over 2 days. After giving immunoglobulin, fever subsided and the symptoms started resolving. We went on to HFNC. The repeat RT-PCR was also positive on day 8 of life. Day 15, again, the child continued to have symptoms, fever, tachycardia, and increased oxygen requirement. And then we said, okay, let us repeat the screening. Nothing came positive. And this time IgG antibodies was sort of positive. RT-PCR became negative. But we started showing an elevated inflammatory markers, including the LDH. IL-6 and D-dimer were all elevated, and there was no evidence of infections. We said this is classical of MISC newborn, so went ahead and gave intravenous dexamethasone. And 1 week after completion of dexamethasone, all the markers settled down. There was improvement in the cardiac function, and this child was discharged at 35 weeks. And there was, as you say, there was an improvement in the regurgitation in this child. If you look at the Indian experience, there are 1,700, and this is reported Indian registry, 1,711 in newborns were born to SARS-CoV positive mother. For 1589 was intramural, 122 were extramural. 144 out of 1313 units which were positive from the intramural, and 39 out of 104 were extramural. 68 were positive on day 1. And see, the main thing was perinatal transmission and horizontal transmission, that 21 were coming after birth. The extramural infected neurons more likely to present with pneumonia, seizures, and septic shock. So you see, majority of the hospitals in this were public sector hospital, very few were private sector hospitals, and those were extramural. This outborn babies were the one who came with this pneumonia, septic shock. There is one more interesting observation which was also shown, that after 72 hours, neonates rubbing with mother were high risk of transmission. Most of them were asymptomatic. The most of neonates who were COVID positive remained asymptomatic. Those who were prematurity had morbidity, was one of the morbidity, and were significantly more likely to need resuscitation, an ICU admission, abdominal X-ray, and need respiratory support. Now, I just would like to sort of talk about what has been our experience. So first wave, we had nearly 58 in our center, 11 other center, COVID positive mothers delivered with us. 6 newborn turned positive out of this. So in the first wave, we were not admitting sick mothers. 5 were positive on day 1. Another 5 COVID positive extramural were treated. So in total, 11 COVID positive were treated by us. All 11 survived and went home. In this wave, we converted 2 of our units into exclusive COVID centers. So 63 in the centers where I work and 19 in our Vikrampuri branch, we have said. So total 82 COVID positive mothers were delivered. 6 neonates in our center and 1 from the other turned COVID positive. 7 outborn are positive. 3 are still being treated, 1 25 weeker, 1 25 plus 4 weeker, and 1 31 weeker. If you look at COVID positive pregnancy at Banjara, we had ward admissions where, like, we divided them, and when I looked at this, 5 were the ward admissions which were less than 26 weeks. 8 we managed them, they were managed in the ward and sent home, didn't deliver. Only 1 had to, there was intrauterine fetal death. She came with no fetal heart. More than 34 weeks, 2 were sent home after sort of managing their fever and respiratory distress, and 27 had to be delivered. So I would say 10, 15 could be sent home. 20 required ICU admissions. After 20 ICU admission, less than 24 weeks, 3 we managed conservatively. 1, she went into abortion. She was very sick. She has a CT score of 25. Between 24 to 34 weeks, we had 4 who were managed, treated. They required high HFNC, they required ventilatory support, and then treated well and sent home. 5 were delivered because of worsening respiratory status of mother. But in the more than 34 weeks, majority of them have been delivered. If you look at the type of support which they required, of those who delivered, 4 required HFNC, 7 required intubated. For those who were intubated, you could see majority of them had CT score of 15 to 19. Plasma requirement was 2 and 2. And see, plasma treatment, again, as you know, there's a big controversy about plasma. The ICU stay has been long. I have some of the mothers who are still sort of ICU for nearly a month. The gestations have been 25 and 26 weeks, 2, 31 weeks, 3, 34, 36 weeks, 4, and more than 37 weeks, 2. Those who have continued pregnancy in spite of being admission in ICU, 2 were in HFNC and 2 were in RM, which means anyone who got intubated invariably end up being ventilated. But even if they were in HFNC, when the CT score which were 10 to 15, by efficient management, they were able to be sort of continued and sent home, including those who were less than 24 weeks, 4 were 24 to 31 weeks, and 1 more than 31 weeks. This is a split about what happened. So of the 5 neonates who were positive, 1 was MISN, which I just spoke to. 1 was a 34-weeker, 3 were asymptomatic. Of the oddborn who were positive, 1 was seizures, 1 was sepsis with hyponatremia and encephalopathy, 2 had RDS with CPAP, 1 had RD with low flow oxygen, 1 had sepsis. All 11 neonates discharged. Of the 63 positive babies, we have 2 who were less than 26 weeks. 1 was 35-weeker who's 2 days, 37-weeker who's asymptomatic, and 1 is 32-week. The 7 outborn babies who are COVID positives. In total, we have 24 neonates who are COVID positive of all the babies who have been delivered. That is 63 and 69, so nearly 132 neonatal deliveries. All this could be possible with all the nurses, doctors, and my team sort of were very committed in taking care of, who took all these precautions in sort of taking care of this very sick mothers, sick babies. So thank you very much, and I'm open for questions. I'll stop sharing. Yeah.
Thank you very much, DINESH, for the excellent talk covering all aspects of COVID, starting from pregnancy to delivery to the neonatal period, all the logistics, the tests we had to do, sharing your experience, etc., etc. And we, NNF Malappuram, is so glad that we selected the right topic and the right speaker, and that's why we were able to reach up to 100 participants for a district CME. Is somewhat equivalent to a state level CME. Now it's over to questions. Probably I can go through the list. There was few here. Or if anybody wants to ask questions, they can unmute and ask, please. If anybody wants to ask questions, please unmute and ask, please.
Someone is asked about someone wrote to me about steroid regime which is followed in COVID itself in pregnant women. Any adverse effect on newborn? See, this has been steroid effect in COVID in pregnant women, as there are 2 types of regime. One is giving dexamethasone. When should be given? So any mother who's requiring oxygen, she requires steroids. That is when, so or has a raised inflammatory markers. So which steroid to be given is the next question. So then countries like US and the Australia, New Zealand, they stuck to dexamethasone and they're giving 6 milligram once a day for 10 days. Whereas the UK is sticking to prednisolone or hydrocortisone compared to dexamethasone. Now, any adverse effects? See, I do not know whether people have checked the head circumference of these babies who are born. What is the long-term effects of giving the dexamethasone for this dose for this long? But what has been recommended, because we are, as you all know, it always priority comes to mother's health during this stage. So it's always important to give dexamethasone or one of these things, prednisolone, whichever regime you choose. And I think that is something which we are again going to are reviewing and come up. But it sounds like probably dexamethasone is probably a preferable one because it's important for us to take care of mother. But if you have a delivery which is imminent, because that is given only once a day, then what is being done in US and other things, you give betamethasone in a regular regime, or you give dexamethasone for antenatal steroid regime, so that the child gets protected and not the once a day regime which we normally give for the COVID.
Okay, there is one more few questions here. Is CT recommended in a pregnant woman?
A very good question. So it's something which I has reviewed. See, the CT radiation, women can take up to 5 gallons of radiation without problem. And see, the recent the guidelines from the Obstetric Society, another thing is the amount of radiation which a fetus get exposed during one CT scan or 2 CT scan does not cause any major damage. So any pregnant woman, if her clinical condition demands her to have CT scan, she should go ahead and have CT scan. And that radiation is not a problem for them. Of course, they should take the precaution by speaking to the radiologist of saying low radiation CT, covering the abdomen with the lead gown. Those type of precautions you should take. But I think mother's health takes priority, and please go ahead and get the CT scan. But again, what is the indication of CT? What we do find is majority of people, the minute they get COVID positive, they're getting a CT scan. Early CT scans do not carry any meaning. We have got so many patients who come with CT score of 5, and then they come on day 6, day 8 with severe distress, landing upon ventilatory support. I think when you are needing oxygen, when there's a respiratory distress, when there's tachypnea or fever is persistent beyond 5th day, 6th day, that is a time when you should consider, but not sort of early as soon as you get an RT-PCR positive.
Okay, thank you. The next question. In day-to-day practice, when preterms are admitted to NICU and later they may be tested negative at the time of delivery, but during the stay in the hospital for about a month, for example, in the next premature baby, they become positive. Then the question is whether we need to continue KMC or wait for the mother to negative before shifting to room.
So sorry, I didn't get the question, Jachan. So there's a
you mentioned some preterms who stayed in the NICU and their mother became positive during the stay. It was negative on admission, but later the mother became positive. So that is, they're asking about what to do with the KMC. And
it's very tricky sort of. See, this exposes the thing about visitors policy. So what is the visitors policy in NICU is, you need to know if anyone is symptomatic or anyone is COVID positive, they cannot be allowed inside the NICU. So mother to enter the NICU, she has to be negative or she has to be symptom-free for at least more than 72 hours to be allowed to be able to enter the NICU. So what we are doing in our NICU is, if we say mother is negative, then we are promoting KMC. Otherwise, we won't. We are at this stage. See, there are two things what I personally feel. See, we are very strong supporters of KMC and we are doing it. But two things. One is mother should wear mask when she's entering to the unit. That is one precaution. Take all hand sanitizing precautions. But of course, we also have sort of responsibility towards other babies and other people in the unit. So we're saying that mother should not have any symptoms, and if she is COVID negative, then only we are promoting KMC in these babies. Because we had one of the preterm babies who was ready for discharge, and then mother became symptomatic, and she kind of COVID positive. Then the child came out positive, COVID positive, and then we had to admit the child. So that cycle goes on. And see, fortunately, the child didn't have any problem. But I think there's so much anxiety it creates. And in one of our center in Bangalore, there's a 24-weeker who did very well, almost sort of gone home, but then picked up a COVID positive and came with bad COVID pneumonia, and had to be ventilated very hard. So these are very, very difficult situations. So I think we have to take all precautions in prevention.
Okay, just one or two small doubts for me. Is it must to use the viral filters when we are treating this type of babies? And if yes, which company produces filters?
See, Draeger is the one company which produces filters.
Which is Gregory.
Draeger produces filters.
Draeger.
Draeger.
Okay, Draeger. Yeah.
So, see, we did extensive review last time. As I said earlier, we used to be quite sort of using it for all the deliveries. Lately, the use seems to be slowly coming down. But I think when you are ventilating, I would say at least any aerosol generating procedures, we probably do. But I think when you're going for regular deliveries and this thing, sometimes it is becoming challenging to do that. Um, as I said, is there evidence? Has it become a standard routine practice? I don't say that there's a strong recommendation for or against it. There are some units which are practicing, some units are not sort of worrying about it.
Okay. One more small doubt: the nurses and junior doctors will be spending most of the time in an ICU, especially if you're starting a COVID ICU. How much chance of getting COVID from a newborn ICU if you're using incubators and all the other personal protective equipments? Because you looked after such babies for more than 1 year now. What was the incidence of COVID positive getting from the babies to the staff, not from the mothers?
See, I tell you, I'm facing that crisis now. And I'll tell you one thing. See, the tidal volume of babies are very less. And they say that baby actually causing infection to the staff or this is very, very less if you actually look at. So when a lot of time it is, many of the people are actually coming positive from outside. See, in the pandemic, what has been our experience is majority of our healthcare staff, let it be nurse, let it be non-medical staff, paramedic, they got it from their home, they got it from their hostel, they got it while traveling, rather than sort of actually being, because they're at their best sort of precautions when they're in the hospital. So this is what it is. So having said that, what has happened is, saying that the newborns are, the chances are little less, people have taken off the guard a little bit. So I would say, please don't take your guard off. Please use your N95 mask well. Please wash your hands well. Please wear your PPEs well when you're taking care of these babies, because that is the only way you can prevent COVID. And of course, I'm sure most of you got vaccinated. So that is the only way we can sort of. So yes, some of our staff are positive, but fortunately, no one is very sick because they all are vaccinated.
Thank you. Any more questions, please?
There's someone says, any clues to differentiate between HLH and MIC in newborn? We have 2-week-old neonatal present with AKI requiring PD, developed sepsis during recovery, had fever. Was also having hepatomegaly, investigation showing LDH F5000, D-dimer of 5000, hypofibrinogenemia, bicytopenia, elevated triglyceride, RT-PCR negative, and COVID-1 is evident. Don't know if it's HLH or MIC. See, very difficult scenario. I think you have a little bit of overlap between both, and here you have an organ involvement is more of your hematologic these things. You have some bicytopenia is there, fever is there. I think if you have more sort of positive COVID antibodies, evidence of inflammation, and then you probably tilt in. And because this is more of pandemic time where you're seeing more of COVID, that is where you probably tilt more towards MIC, a newborn side. If we, on top of it, if you're able to document something like there is some amount of cardiac dysfunctions, you document some elevated pro-BNP or troponin levels, then you probably shift more towards MIC. But if there are nothing like that and you can't have history of exposure to COVID, your COVID antibodies come negative, or RT-PCR come negative, then probably you tilt more towards HLH. There's one, when to take routine immunization bound to, I think there is routine, the NNF guidelines says continue immunization practice as routinely. There is no separate this thing. What is the incidence of premature delivery in COVID positive mother? It says, I mentioned it is almost doubled. There's some people would say from the 8 to 10%, it has gone 17 to 22% is what has been said. And okay.
I think we will wind up now. I know you're talking for more than 1 hour now. So once again, thank you very much for enlightening us with all aspects of COVID and also sharing a great experience. And I'm so pleased to see this much good attendance from even outside Kerala people and outside India listening to this talk.
Thank you.
And we'll be calling you further also for different topics in the coming months.
Thank you.
And now the time for official vote of thanks. I will request our NNF Treasurer, Dr. Bindu, to convey the official vote of thanks from NNF Malappuram. Over to Bindu.
Good evening, everyone. It is indeed a great honor that we are able to hear from the best from a great speaker, Dr. DINESH CHIRLA, sir, about neonatal COVID management. Thank you, sir, for accepting our invitation and the informative talk. On behalf of NNF Malappuram, I would like to thank Dr. T.V. Ravi, sir, President NNF Kerala, for the inaugural address. And I wholeheartedly thank Jayaraman, sir, Murali, sir, Nelbi, sir, for supporting us. I thank Dr. Jayachandran, President NNF Malappuram, for the presidential address and guiding NNF Malappuram in an excellent manner. And I thank all the participants for attending our program. I thank my colleague, Dr. Moideen Babu, for organizing such a wonderful program. Once again, thank you. Thank you all. We'll meet next month. Thank you and good night.
Good night. Good night, everyone. Good night, Dr. Ravi.
Good night, sir.
Thank you, everyone.
Good night, Jayachandran. Good night.
Good night.
Yeah.
Thank you, sir. Good night.
See you, Dr. Dinesh, later. I'll catch up with you later.
Yeah.
Thank you.
Bye.
Thank you. Thank you, sir.
Thank you, sir.
The meeting is dispersed now.
Yeah.
Dinner will be served. If you ordered it in parcel, it will reach your home. At the moment, it will be any moment it will be shared to you.
Okay, that's great.
Thank you.
Okay, sir. Thank you. Thank you, sir.
Sir,
Okay, bye.
good night all. Bye bye. Thank you, Jayendra.
Good night, all. Okay, bye.
Yeah.
Okay.